Hi guys, I'm going to talk about the non-English speaking population, environmental and cultural factors. Most health concerns with this population are due to communication barriers, which result in adverse medical outcomes, poor compliance with therapy, and poor understanding of medical conditions. Some studies reported this population had multiple disparities in healthcare, and these include lack of a personal primary care provider, suboptimal oral health, higher rates of obesity, speech communication problems, or lack of health insurance. There are some stereotypes of non-English speaking population in the domestic and international media. Most individuals of this population in movies are poor, refugee, immigrants, and maids and so on. I think it is inaccurate, and these inaccuracies would place this population at greater risk for being misunderstood. For example, I'm a non-English speaking person in America, but I'm not poor. I have a good job being respected by most persons in my hometown. Family support plays an important role in health outcomes for this population. Family members communicate with each other without any barriers. They can share the same culture and the same diet. When one of them faces stress, others would provide support and help, which benefits both mind and body health. Peers can play a supportive role in health outcomes for this population. There are many clubs for them. They can make friends and unity. They can support each other, making sure they are not alone. When it comes to cyclical nature, I think it depends. In many families, only the first generation has a limited English ability, while their children and grandchildren are born in this country so that they receive the English-speaking education. Some of them could better accept a different culture. On the other hand, others cannot be assimilated by the different culture. There are more and more legal and political systems helping this population, but it varies among local, state, and national levels. Utah has been doing great in this aspect. There are many resources supporting this population. Recently, I watched a video online. Utah government cheers for China during the time of fighting COVID-19. I feel so supportive. It means this state has a good relationship with other countries, so this population in Utah would feel supportive as well. Language and cultural barriers make this population more vulnerable within a larger community, resulting in misunderstanding in the clinical settings and not meeting patients' needs well. On the other hand, it can lead to poor medical compliance. There would be more communication barriers among neighborhoods in the larger communities. In terms of international scope, this population would be in danger or shunned in every region where the English is native language. It's because problems arise when English is a second language to either speaker or listener, or both. No matter how proficient they are, their own understanding of English and their native language can change what they believe is being said. Socioeconomic status play an important role in affecting health outcomes within this population. As the video resource mentioned, individuals in the high income and educational levels could get better access to health care, and the quality is better. The reason is that high-quality medical services are more likely to be located in wealthy communities as opposed to poor areas. Disease is more likely to spread within crowded living conditions. Individuals with a lower social class are more likely to take jobs that put them in dangerous environments. which could lead to accidents. They are also more likely to take jobs that involve health risks. Also, individuals with a lower social class simply cannot afford expensive treatments and prescriptions. Race can play an important role in health outcomes within this population. African Americans, Asian Americans, and Hispanics tend to have worse access to health care, and the health care they receive tend to be lower quality. The main reason is that people with different races would result in different socioeconomic status. Although some of them are wealthy, there is still racial difference in health care. Religion also can affect health outcomes within the population. Many studies found religion to be positively associated with mental health outcomes as adjustments to stress, well-being, hope, meaning in life, quality of life, social support, and self-esteem, while negatively associated with rates of depression, drug use, antisocial behaviors, and crime. A literature examining the relationship between religion and physical health outcomes is similar, with greater religion associated with better cardiovascular functioning, lower level of chronic disease, better immune functioning, reduced stress levels, and greater longevity. There are also many gender differences in health and healthcare within this population. Men tend to use fewer preventative services like vaccine, even when they are available to it. Women require reproductive services, but sometimes the access to these services are reduced by local policy. Additionally, there are fewer disease research involving women than men, and these symptoms of diseases can differ by gender. Women suffer from this lack of medical research. Another group, transgender individuals, is more likely to suffer discrimination from within the healthcare system, which can limit the clinics that they feel comfortable seeking help from. Geographic location could affect health outcomes. If there is no medical services close to their community, this population tend to get worse access to health care, and this is especially true for those living in food deserts, because having a poor diet could impact a person's health. In that case, the telehealth would play an important role in enhancing health care. Telehealth could support long-distance clinical health care, health-related education, public health, and health administration without any geographical barriers. Non-English speaking population face implicit racial bias exists among causing disparities in access to health care, the quality of care received, and health outcomes. Another implicit and explicit bias is a cultural difference and communicational barriers. For many health providers, caring for non-English speaking patients was more challenging because it took more time and impacted nurse productivity. It's a common issue within the international scope, so it's hardly to say which regions of the world have fewer disparities or less influence on health for this population. However, many regions of the world have been managing to address this issue. They employ medical interpreters in clinical and hospital settings. They can help patients of this population. Moreover, a study conducted in the US reported that ensuring the patients have appropriate writing information in their native language regarding their diagnosis, treatment, and medications can improve compliance with therapy. Making sure interpreters ask patients questions in several ways may help resolve concerns about obtaining important information. Repeating patient-reported information back to the patient via interpreters can also help ensure the patients are being understood and their concerns addressed. This will reduce the difficulty with poor compliance due to lack of understanding. Future studies would be useful to address the known disparities regarding health insurance data or immigration status. In addition to looking for other potential barriers patients or families may perceive affect their encounters with healthcare providers. They are my references. Thank you.